I would add two more points to these excellent points. One is that asymmetric hypertrophy does happen in amyloid. It's not the norm, as Dr. Kari was saying. That lateral base thickening is really a good sign, but don't rule out amyloid just because someone has asymmetrical hypertrophy, especially if the lateral wall is still thickened. The lateral wall could be 12 millimeter, could be 11 millimeter, but your septum could be 16, 17. That doesn't mean that the lateral wall is absolutely normal. If you think about your young HCM patients, they would have a septum of 20 and the lateral wall would be 8 or 7 millimeter. That's a true asymmetrical hypertrophy in the sense that you have no increase in thickening of that lateral wall. The second point that I was going to say, that so for patients with variant disease like black patients, which are studied well in the United States, 25% of them have wild type. So just essentially taking care of black patients and saying, I'm going to just do the TTR gene sequencing, and if it's normal, I'm done, it actually would make people miss one-fourth of the patients. And so I remember it's phenotype first. Genotype first helps in certain scenarios, but for now, amyloidosis is phenotype first. We need to go after the phenotype and come back.
I think, with this disease, we've all these rules, but a lot of these rules were made when we were scanning patients with much more advanced disease. So as we learn more, as we're diagnosing it earlier, some of these rules aren't as kind of cut and dry, like exactly what this case pointed out, the posterior wall thickness that Ahmed was pointing out. I can't just say just because it isn't there, it's not amyloid. If the other features are raising the suspicion, you kind of go with it.
Thank you both for the great presentation. So the S prime was a great tip, by the way. Did not know about that. The question that I had was, in terms of different kinds of subtypes of amyloid, AL versus TTR, and two kinds of TTR, what are the echo differences between them? Are there any differences? If they are, how are they different?
Yeah, that is a super question. So AL amyloidosis, we spoke a lot about these light chains. So the light chains have a degree of toxicity. So sometimes we call it a toxic infiltrative cardiomyopathy. So one of the giveaways is that the patients can be a lot sicker for the degree of wall thickness and doing a lot worse. But otherwise, if you were just to see the echo, you had no idea what the patient, how they were doing, any other clinical information. Just on imaging alone, there's nothing that you can kind of pin down on echo. Some people might say, oh, the atria mightn't be as big in AL because it's kind of developed quicker, the atria haven't had time to dilate. But just based on echo features alone, you cannot distinguish AL from ATTR. You need some other clinical information.
I agree. I always tell our fellows, thick but not too sick should be essentially something that makes you pause and think about it. We see this a lot with MGUS. So patients send us, referring physicians send us patients who have a fairly thick ventricle. We're talking about 1.8, 2 centimeter ventricle. Patient has very elevated lambda or kappa light chain, but they're doing amazing. And so you still have to go through the process, but at least you might not need to run while you're working the patient up. For example, in our practice, for every amyloid referral that has not had light chain workup, either gets light chain workup within 1 to 2 weeks, if we can, based on how we can review the referral, or we see them within 2 weeks. Because we have had scenarios in the past where we lost patients because of delayed, essentially, workup and evaluation. The second thing is that with light chain amyloidosis, you can have a 1 centimeter septum. You can have a 1.1 centimeter septum. You can. But it's so clear. The heart looks stunned from the toxicity of the light chain. Because light chain amyloidosis, there are two types to the story. One is toxic cardiomyopathy, from the light chains themselves having toxic potential and causing as if myocardial injury. And the second one essentially is the infiltrative potential. There are AL patients who have a 2.2 centimeter heart, but those are not common. But they do exist. And those are the ones that actually shrink, like after a while after treatment, you see their walls come down tremendously. So I agree that there is no clear way to differentiate on echo or MRI, actually, AL versus TTR. However, you can have a sense, and that sense of urgency really needs to be there for all amyloids, in my opinion, to get people to get worked up and treated, because delays in recognition and treatment of light chain amyloidosis means essentially really death, and we see this day in and day out. Recently we lost a 39-year-old, previously healthy, AL, delayed diagnosis, death. And so these things are real, and so I think we need to have that sense of urgency when we think about this.
I would like to congratulate both of you for the very nice presentation. In fact, I would like to address to you just two questions. How far can we trust on this apical sparing pattern, concerned that we can have this in other forms of hypertrophic, different phenotypes, and also even in normal patients? And also, how can we go to the early diagnosis of amyloidosis, which is absolutely great, it's very important. Whenever you have, for instance, Perugini 0 and 1, I would like to see your ideas on that. Both of these two questions, and if the MRI could be something interesting concerning the early diagnosis of amyloidosis in this Perugini 0 and 1.
So I can start. So there is a new multi-center study that I think will push the strain story a little bit. We actually tried to do it as a single center in 2017. We couldn't get it published, showing how there is a lack of, the sensitivity and specificity are not 90% for sure. And so we couldn't get it published, and then I actually abandoned the paper altogether, even though it was there. Now there is a multi-center study with almost 600 plus patients showing that the sensitivity and specificity is around 65% or so. You're right, some controls had it, some normals also had it. What I would argue is that's for all comers. Once you start essentially taking patients who you think clinically could have the disease, I think that improves a little bit. And it really works if you don't have aortic stenosis, if you don't have hypertension, and if you don't have kidney disease. And the clinical picture doesn't fit hypertrophic cardiomyopathy. You might say, well, why would you need then strain? I would argue that a lot of the patients that we see actually don't have any of the four. They have just moderate LVH, and everyone attributes moderate LVH to that history of hypertension. We see this all the time, and so that's, I think, where strain is helpful. To answer your second question, so for the lower grades of bone scintigraphy, anything aside from diffuse SPECT uptake for me is non-diagnostic. I actually take it a notch up from the guidelines because we have seen, because when you have a focused practice, you see zebras all the time. And so grade 0, 1, 2, that's not enough. You always, anything aside from diffuse SPECT uptake requires further workup. This could be MRI, this could be endomyocardial biopsy, this could be, both of our programs have access to fancy new PET tracers that we try sometimes on investigational, for investigational reasons, and so we sometimes try some of those. But ultimately, I agree with you, you need to identify it earlier. I hear in the UK, they do lots of imaging-based diagnosis. So because they have super easy access to MRIs, almost 2/3 of their patients are referred through the MRI route to the amyloid practices. In the US, essentially, that number is probably less than 5% because we don't actually do as many MRIs. But I think that also contributes to earlier recognition and less outcomes, less bad outcomes, essentially improved survival, because they are identifying patients early through the MRI route. Can you do MRI for everyone? I don't think so. At least in the United States, this is very tricky. I think in centralized healthcare systems, it could be easier. When you have LVH, you should consider phenotyping the LVH. And if you have a policy to do that, I think you can serve not just amyloid patients, you can serve lots of other patients, including HCM and other diseases.
Yeah, I agree with a lot of those points. Maybe not so much about the grade 2 uptake. I consider grade 2 uptake diagnostic. So again, I really just see patients who are referred with the concern of cardiac amyloidosis. So I definitely see patients where I look at the echo and I'm like, oh, thick wall, perfect apical sparing pattern, it's not amyloid. But those patients are few and far between, and I think warrant going through the whole workup, nearly to the point, essentially to the point of biopsy, unless it's really clear cut that they have end-stage kidney disease or on dialysis. But even at that point, it can be really challenging, because if you do serum free light chains, they can be very abnormal. So often we end up going to a biopsy with those patients, but they're few and far between. And that's kind of doing strains systematically on a lot of these patients with increased wall thickness. That is where MRI is helpful, and MRI kind of jumps around in the algorithm that we showed. So some people, when the echo shows the suspicion of amyloidosis, they'll say, oh, I'll get an MRI next. Well, if everything fits with TTR, you don't really need to. You can go to your PYP or HMDP scan. I think MRI is most useful when the question still hasn't been answered. So exactly what you said, if you have the echo that looks classical, you thought it was TTR, you did the PYP scan, it was either 0 or 1. MRI can really help you there, because if the MRI comes back showing classic amyloid, well, you know you got to get a biopsy. Or if the MRI comes back showing another etiology of the LVH, boom, you've got an answer. And a PYP is usually a pretty easy test to get. It's pretty cheap, as far as I know, and should be easy enough to interpret. But I think in these patients that you mentioned earlier with the increased wall thickness, end-stage kidney disease and apical sparing, we don't know really what their MRIs look like. So some of them can have pretty diffuse fibrosis that can be very challenging to tell apart from early amyloid. So MRI, even though it's the same with echo, you know, once the disease is very established, you can tell it very, very easily on MRI. But we still don't know exactly what the MRI features are of very early disease either.